Good afternoon, ladies and gentlemen. Thank you for being here. We'll call our meeting to order, and this time I'll recognize Brandy for our invocation.
Our gracious
Amen. Thank you very much. Let's stand together for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, everyone, we have item number 4, approval of the agenda. You received the agenda in advance of our meeting today. Do I hear a motion that it be approved?
Motion.
Thank you, Dr. Frank. Have a second? Second. And second, all those in favor signify by lifting hand. That is all of us. Thank you very much. Also, you've had the minutes from our previous meeting. Any questions or additions to those minutes? Seeing and hearing none, I'll entertain a motion to approve the minutes. Motion. Have a motion. Do I have a second?
Second.
Have a second. All those in favor signify by lifting hand. I believe that's all of us. Okay. This brings us to presentations today. We have several presentations, and with that, I will turn this over to Dr. Katie Samuels. Katie.
Thank you. Thank you all for coming to our special meeting. This meeting was called as a time for us to be able to hear from the providers that submitted proposals for our very first RFP process. And these providers were vetted through an internal review, and we met also with our council or committee to talk through these and decided to have this special meeting to hear directly from the providers. So I want to give you a little bit of a recap of where we have been and how we got here and what our next steps are. So our discussion today, I'm going to give you the department recommendations, and then we're going to hear from each one of the providers. Following each of these presentations, you all will have an opportunity to ask questions and interact with the provider representatives to learn more about what they're doing, and if you have any questions that you want to have answered. And then finally, what we're moving toward from this process is endorsement of selected strategies or proposals to move to the Board of Commission for final approval. So with your endorsement, we'll be able to take these proposals to the Board of Commission for final approval and start implementing some of these projects. So as a reminder of our priorities, reduce the onset of new use, enhance pathways to recovery, and reduce fatalities. And so what we've seen with the data that we're collecting locally is that we have made an impact in reducing fatalities. And we want to prioritize the enhancing pathways to recovery and reducing onset of new use while maintaining that reduction in fatalities. And so how we got here. So back in June, we released our RFP or RFA June the 13th, and it closed on July the 11th. So we had a window of time for providers to submit proposals. And we really wanted to hear from the community and the community providers about what can we do here, where can we expand services, or what new services can we start, and really engage our provider network to see how we can strengthen it. And so after the RFP closed, we had an internal review where we looked at alignment with the MOA and other qualifications that just making sure that the proposals met everything that we needed to for the memorandum of agreement and alignment with priorities. After that internal review, we had a committee review of the 4 selected proposals that passed through the internal review. And then we had follow-up interviews. So our county team met with each one of these providers, asked follow-up questions, really dug into what they're proposing, how it's sustainable, what the plans are past the funding, and looked at how we can create a strategy basically to strengthen our provider network and move forward with some strategies that would do that. So in August, we refined our performance-based contracts because a lot of the questions from you all is like, how are we going to be sure that this works? How do we make sure that the money that we're spending is really impactful? And so we used the contract tool to create some parameters around that. And now we're back here at this committee meeting to hear directly from the providers and let you have the chance to interact with them with the goal of recommending programs to the Board of Commission at next week's August Board of Commission meeting, so that in September we'll be able to finalize the contracts and start implementing some of the programs. So if you think about that, in 4 months we've really done a lot. So the total proposals that we received were 11. After the internal review, we moved forward with 4 of those. One of those was the Good Samaritan Clinic, and when we did the interview process internally after our last meeting, what we found is that the proposal didn't really pitch serving the majority of opioid use or polysubstance use disorder affected individuals, and so it might align with a different source of funding rather than opioid settlement. So while we originally had 4 proceeding, that's now at 3. And so some of the other proposals that were not proceeding at this time were either duplication of existing services, didn't meet a strategy in Exhibit A, misalignment with identified priorities, or did not serve a majority population impacted by OUD. And so we do have a tier of proposals that we want to go back and revisit, also do some interviews with these providers, look at how their strategy or vision for what they're proposing might meet the criteria and refine it a little bit. So recommended to proceed at this time, we have a Caring Alternative, High Country Community Health, and Spark. And so these are all high impact, high need strategies. They're evidence-based, and we've developed performance-based measures around these programs. And also it's like a fee-for-service model. So we've designed it so that if nothing's done, then there's not a payment. So it's kind of like a transaction where we can give you guys some peace of mind of like we are getting something that we're paying for. And so a Caring Alternative, the requested amount is up to $300,000, and this is for Substance Abuse Comprehensive Outpatient Treatment, or SACOT, and Substance Abuse Intensive Outpatient Program, SAIOP. And they're structured evidence-based treatment programs for individuals with substance use disorders. And if you picture our continuum of care of being outpatient services and hospitalization, this is right in the middle. So it can either help prevent people from having to go into inpatient care, or it can be a step down of when they leave the hospital, they have some place to go to where they're not just going directly back into outpatient. And so in our provider analysis, this was a gap that we had of services in the county, so we don't have a provider that's offering this inside the county at this time. And while this is a big component of recovery court, the referral sources into SAIOP or SACOT can come from anywhere. They can come from our port team, they can come from the jail, they can be self-referrals, so it's not just something that goes along with recovery court. So SACOT is 5 days a week, 4.5 hours a day, and SAIOP is 3 days, 3 hours per day, so it's pretty intensive. And this is directly pulled from the contract about what kind of milestones we're looking for. Like, when do we expect to see this up and running, because this is a new service that will be established. So we're looking at 2 groups running by the end of month 9 with the goal of 1 evening and 1 morning group per each service by the end of the year. And so some of our outcome measures are here, and this is pulled directly from our drafted contract. But I also wanted to share with you some national statistics. So 60% of people reported abstinence 6 months after completing SACOT, and that was from Coastal Horizons. That's a North Carolina provider here. And then 50 to 70% reported abstinence 6 months at follow-up from IOP, and that is from the National Library of Medicine. So we're seeing the evidence supporting these services. And if you look at the outcome metrics there, again, we're going to be actively managing the incoming data to be able to report back to you all of this is what we're doing, this is how far we've come. So High Country Community Health requested amount up to $199,000, and this is for low barrier MAT. And some of you guys, Tim here was actually featured in a book about the program that he was already doing in Burke County. So this is an expansion of what they're already doing. And so this provides same-day or next-day access to medications. It also addresses social determinants of health and helps people connect with other resources. So it's really meeting people where they are, getting them engaged so that if they choose to, they can get into things like SACOT, SAOP, or other treatment modalities. And so our implementation milestones here, we're looking at startup of hiring additional staff, program launch and outreach by months 3 to 6. So fairly quick startup and expansion of capacity there. So some national statistics also that support this is there was a 72% retention rate in treatment reported in low threshold programs like this program that we're proposing. And in low barrier or low threshold programs, there was an opioid use dropped from 90% to 41%, and that's from SAMHSA. And so Spark is our third proposal that we'll hear from today with a requested amount of up to $390,000 for family-centered treatment recovery, FCTR. And this is an intensive in-home program that blends substance use recovery support with family therapy. And so this really will have a ripple effect on some of the issues that we're seeing with our foster care system and help meet some of those needs of people even before they're coming into the foster care system. So we're looking at using it as a preventative to keep people in their homes, to surround them with the support they need of a team of peer support, social workers, and other clinicians that can help get that family where they need to be. So these are local statistics from June 2024 to July 2025. We had 186 removals. That's kids being removed from the homes. And 78% of those removals had a substance use factor involved with it. So that's really, really powerful if you think about ways that we can support interventions that not only impact our foster care issues, but also the substance use and opioid use that are the root cause of some of this. And so now I want to turn it over to our providers and let them tell you a little bit more about what they're proposing to do. And then at the end of each one of their presentations, you'll have the opportunity to ask them some questions. So up first, we have a caring alternative. Here you go. There, it's kind of on my nose. Okay. I usually go backwards accidentally, so you just look at it.
Yeah, we may go forward, we may go backwards. Here we go. Good afternoon, everybody. I am Tegan Brown. I am the Chief Operations Officer with the Caring Alternative. Renee, you want to introduce?
Everybody, I'm Renee Brackett. I'm the Adult Services Director at a Caring Alternative.
And it's good to be with familiar faces. There's been many of you that I have worked with for years, served on collaboratives with for years. Johnny Carswell, let's see, he was on our nonprofit board, and it's really good to see everybody again. And we will get started. So A Caring Alternative was founded in 2006 by Malena Roney, who is in the crowd with us today. She has this vision of innovative healthcare approaches to integrate both the physical and mental health and substance use, whole person care. And let's see, we actually started, I think that's on the next slide, our approach to care is that we employ approximately 200 employees that follow our agency's mission, philosophy, and our values. We have the care values that, we meet people where they are. It's commitment. It's about committing to these quality outcomes, achievement, enhancing the skills, and being resourceful, and empowerment. Because at the end of the day, that's what we want to do. We want to empower people to take control of their own lives and their journey of recovery. Okay. ACA was founded right here in Burke County in 2006. We've served hundreds of clients since 2006. This is our hometown, right? We love to play here, work here, and live here. So we're very proud to be centrally located in town, just a couple blocks away from here. And we do have, let's see, Katie, you might have to help me here. Can I click on this link?
They might be able to click on it for us back there. The wizard in the box.
Can we click on the link, please? Thank you. That's where they were. Okay, so within Burke County, we do offer the full continuum of services, including a walk-in clinic, so same-day assessment and access to services. No appointment needed. We also, if you want to keep, can you scroll down, please? Thank you. So we do serve the child and family population for Burke County specifically with substance use, and that is in our outpatient therapy program. Med management, we have a service called hospital discharge and planning, which there is someone that's embedded at Grace Hospital to be able to help get the person into services that they need. And you'll see some of these duplicative services in the adult services as well.
So I can tell you that I've been with this agency after retiring from Broughton Hospital and moving to community mental health. I've been with this group for about 14 years, a little bit more now. The growth of this company has been unreal. Melena Roney has pushed us. Sometimes Tegan and I are like, ooh, we don't want to start that, we don't want to do that. But Melena has said, no, this is a need, and that's how this company started. Each of the services that you see in the PowerPoint, we've multiplied and moved on. What we're proposing now is the next step to serve this community. So you know this company has been here and it's growing and it's doing everything it can to meet the needs. And when it sees a need, it acts, and then it says, okay, we can do more. Maybe we need one group, maybe we need two. And that's what we're proposing today.
And that is exactly, why we felt compelled to apply for this RFP. We had identified internally that while somebody presenting with mental health issues and co-occurring substance use, absolutely, we could get you into whether it's peer support services, community support team. And if you'll scroll down, we'll keep talking about some of these. There's a continuum to get folks into services that have that presenting mental health need. Where we've identified the gap in service is somebody presenting truly with substance use disorder treatment. Yes, we can offer routine outpatient, but beyond that, we did not have a full continuum. And so with this proposal, we will be able, a lot of times as clinicians, it's hard to determine what came first, the chicken or the egg, right? Are we treating the substance use? Are we treating the mental health? And so this way, this will allow for a continuum of, we can get the substance use disorder kind of in that recovery stage. Well, then you may have lots of trauma that you're going to have to work on in the mental health aspect.
And as Tegan mentioned, we're already in the hospitals. We've been over here at the old Grace Hospital for a while. working with the behavioral health unit. We used to work with the old detox unit over there. And our role over there is to get people into outpatient services so you don't have that recidivism. Over the last year or more, we've gone into Broughton Hospital now and doing the same thing with the discharges in this area.
Yes. As we mentioned in the proposal, some of our services already have treatment of the substance use disorder population. And those are the Assertive Community Treatment Team. So essentially that's a hospital without walls, just paraphrasing here, as well as Community Support Team, our peer support services, and our outpatient services. We do have a pretty robust peer program within the county, so we're looking to, continue to expand that effort as well. Okay, I'm good there. Thank you. Now I can. We have seen, various success outcomes with both the intensive outpatient program as well as the SACOT program and medication-assisted treatment. We believe that we can launch these services and be fully sustainable within that 12-month period due to having the wraparound services for the adult population. So what is SAIOP? These are both structured groups that will take place. SAIOP is 15 hours of service, up to 15 to 19 hours of treatment per week. The concept here is that the individual can still continue to work and go to school to be active participants in the community versus going to an inpatient setting or having treatment for that long. SACOT, on the other hand, is also considered a partial hospitalization. So that is 20 plus hours a week of treatment. We must have morning groups and evening groups because, again, we want to make sure that our citizens are able to work or go to school or whatever that they need to do, as well as treat their opioid disorders or other substance use disorders. And here's a list of things that will happen. So this is a group and individual treatment, both IOP and SACOT. We will also have family counseling and training. We'll have the biochemical urine drug screens on a weekly basis, so we'll be monitoring that. We'll have life skills planning, prevention, relapse prevention, disease management, crisis contingency planning. There'll be case management. The assessment and reassessment will be very important. That will determine the level of care based upon which group or what treatment they need. When will IOP be offered? They will be Monday, Wednesday, and Friday from 9 to 12 for the morning session and from 5 to 8 for the evening session. The SACOT, which again, that's the 20 hours of treatment, a little more intense, will be Monday through Friday, so it is 5 days a week. Morning sessions will be 9 a.m. to 1, with our evening sessions 4 p.m. to 8 p.m.
And the important thing about SACOT is if it's Christmas and Christmas falls on a Saturday and you got holidays in there, this group still must run.
You cannot go 2 consecutive days without treatment. So let's take Labor Day coming up for our holiday. These groups will have to meet on Labor Day. They can't go more than 2 days without treatment. That's a good point. I'm glad you brought that up. Both for IOP and SACOT, the expected outcome is abstinence, but there's secondary outcomes for just improvement in overall health and psychosocial functioning, reduction in psychiatric symptoms, reduction in public health or safety concerns, and reduction in risk of relapse. What is medication-assisted treatment? I think you guys probably all are very familiar with this type of service, but this will go hand in hand with what the groups are offering. Currently, we partner with High Country, and we will continue to do so, but we do feel like having that in-house, with HIPAA and all the red tape that we have to go through, that it may be easier for that person receiving services. MAT aims at normalizing the brain chemistry, alleviate cravings, and prevent relapse. It addresses both the physical and the psychological aspects of addiction, and it seeks to help individuals achieve full recovery and regain a sense of normalcy. And the desired impact for MAT is reduction in mortality and overdose rates, decreased illicit opioid use, improved social and psychosocial functioning, and increased likelihood of abstinence. Questions?
You guys talk a little bit about, one of the biggest things that we hear across any service is like the transportation piece. And when I asked you guys about that, you had a good plan for using the resources that are already at ACA.
Correct, yes. As mentioned, we do have a pretty robust peer support program currently. Not necessarily that is, transportation, it's not a billable event. However, the ability to get people trained in maybe using Medicaid transportation or using some of the resources that we have could happen as well.
And we have in our proposal a couple peers built in, but you can never negate the power of having somebody in your car. Just yesterday, we have a lady in the audience now who told me this works for us, peer support, who brought somebody to our office from Forest City. We're serving Rutherford County also. And her comment was, you just can't believe everything this guy told me in the car that he didn't tell his therapist. And that helped the therapist and will help all of us learn how to treat this fellow and the needs. And so we feel like, you can have a bus driver that never talks to people, or you can have somebody one-to-one driving and you get so much information and the person gets so much support from that. And we're able to do that through peer support, and that would be our plan.
Yes.
In the packet that was sent out, I know you didn't cover it just then, but harm reduction services was mentioned. Could you just elaborate on what exactly is meant by that?
Yes. So we will be using several evidence-based practices within our treatment programs and our treatment model. So in those, we're going to use the matrix. It's called Seeking Safety, and they have that harm reduction model as well. Within our ACT services, we currently use a harm reduction model. So it's not just about abstinence, and we know that. Again, partnering with High Country and doing syringe exchange and things of that nature as far as making sure people are safe, right, and having those harm reduction skills.
Okay, thank you. That was one thing I wanted to touch on, was the syringe exchange. As someone who's experienced that and been in this world, I think the syringe exchange can actually potentially increase the amount of people that are actually using. Because, for instance, let's say two individuals are hanging out. One of them's never used IV drugs before, the other one has. Well, the guy who has doesn't want to be alone doing it himself, so he's like, hey, why don't you do this with me? If the guy only has dirty needles, person B, who's never used IV drugs, will be less likely to actually use it. So I'm just kind of afraid that could potentially increase our problem And I don't see how it necessarily hits any of the 3 points mentioned. I could see potentially how it reduces fatalities, but that would be way in the long run instead of an immediate issue. And I just don't necessarily like the idea of giving money towards, hey, we're going to make it easier for you to use dope. Again, I want people to realize, look, the thing I remember most when I was about to quit was me stabbing myself 20 times with a blunt needle trying to find a vein. I'm sorry to make it to be blunt, but they need to be able to see that they actually have a problem. And I feel like if we're creating a needle exchange where we're normalizing this issue and we're not showing them that what you're doing is going to bring you pain.
Right.
And so that's just something that I worry about, and I just wanted to bring that up and voice my opinion.
No,
Feel
thank you.
free to push
Thank you
back.
for that. And just to further clarify, as far as, these programs go, yes, the expected outcome is to increase that likelihood of abstinence. Again, some of the other services that we offer, such as ACT and the fidelity to that service, it is a harm reduction model. So some of our current clients, we partner and try to use those harm reduction techniques within that evidence-based practice. But I definitely hear what you're saying.
Yeah, we appreciate that. And there's lots of schools of thought on it, right? ACA is based on, we're going to meet you where you are. And if you are in active use with dirty needles, that's where we're going to meet you. Now, we're not doing needle exchange at this time, but we certainly have supported High Country in their efforts to do that. The other thing about needle exchange or meeting you where you are is hopefully we're going to gain your trust. A lot of us in here have walked in an office for the first time to say, I need help, and that takes a lot of guts. If we can get you in, if we can make a contact with you in any way to reduce your harm, whatever it might be, hepatitis, HIV, whatever it might be, then maybe we can get you in a group like this and move you toward abstinence. But it's all about, in my opinion, for me, trusting that person. And if Tim Nolan says, here's some new needles and maybe you won't get hepatitis, then I bet I'll remember Tim Nolan. But there are lots of schools of thought, on that. You see it on TV, these places that you can go in and use, right? And they just monitor you to make sure you don't die. I mean, we've all got opinions of that, but I appreciate you bringing that up, Jim.
And I appreciate all the different schools of thought, and I appreciate the idea of let's establish a connection with this person. I don't know if this is even the place to bring this up, but I wish that was something that wasn't in this packet that the Opioid Advisory Board wouldn't be paying for, giving dope heads needles. And I'm sorry to put it that way, but I'm from the street, that's the language I use.
Right?
I think we have public comment. Yeah, I think we're gonna have a public comment after their Q&A.
I kind of have a three-step question. Is that okay? Yeah. But first, I do want to say that I think you guys do incredible work, and you have my full endorsement. The amount of individuals you all serve is beyond comprehension. Individuals neighborhoods and backwoods that people don't even realize exist, and people are in there. I've seen it myself. And I think this is extraordinarily important, so our people are not traveling to Catawba County to get the service, and they can get it here, whether it be court ordered or for whatever reason. But I am wondering, since it is a partial hospitalization, are they eligible for, say, CST or ACT while they are attending SAIOP?
No.
That's not your fault, that is a Medicaid rule?
Yes.
Okay.
But they are eligible for peer support.
Okay.
So we would have the peer support wraparound.
Okay, and then, will the sessions ever be blended? So like say you got SA, IOP, and as my understanding, SACOT is Monday through Friday, SA, IOP. So the Monday, Wednesday, Friday, will they be in there with the SACOT individuals, or will those be different groups?
It will be different groups.
Okay,
Yes.
that's impressive.
Yes.
And then, if they can't go more than a couple days, does that mean, like, what if someone can't attend? Are they discharged? What does that mean?
We will have to monitor and follow our own policies, but, we don't, and you probably know this, we don't just say, oh, no, we're going to discharge you. We are going to assertively engage that person, try to get them into treatment and overcome those barriers, whether it's, transportation or I've had this going on, to try to overcome the barriers,
Relapse.
right, relapse.
That's where the peers, I think, are going to be so powerful.
Absolutely. And then with the MAT model also happening at the same time, do those coordinate with each other? For example, someone has to come in daily for their MAT. Are they able to get their MAT and then go straight to their meeting? Do those line up?
Yeah.
That would be
Yeah.
our,
That
yes,
would be
the
our
goal plan, right?
Yes, because okay, thank you.
Yes,
Because we want you to be able to go on with the rest of your life, the rest of the day.
right.
Tegan, I think everybody in the country knows that I particularly am not fond of 30, 60, 90-day programs. I see there's a structured program here that goes for a period of time. I want to know what caregiving alternatives, some of the successes and some of your failures, and do you think these programs are long enough? What happens if a person's in the program? Absence sometimes is not the cure. Just saying no is not it. It's to having the people there. So can you expound to this board a little bit on that?
Yes, I will. So as far as, looking at the eligibility criteria of each of these programs, and then being able to, because again, it may, after getting through and hitting some recovery efforts on the SUD side, there may be this trauma and mental health things that then you have to go that course of treatment. So I do believe that having the continuum of both the mental health and the SUD services will assist with that. So, somebody can be in SACOT, which is this 20-plus hour a week program of treatment, and then they graduate. They're stepping down to routine outpatient, but they still have their support group. They have their peers, going to community events, or, maybe it's meetings that they want to attend. And let's say, and we see this now, let's say, we start seeing this person struggle, well, then we're going to get them reassessed and see what level of care they need. So maybe they need to go back into IOP or SACOT. I hope that, do you have anything to?
Well, one of the things that we're going to track also is if you do graduate and you go on, that we're going to try to keep up with you.
Yeah.
And how are you going to try to do that?
Well, we're going to ring you up, we're going to go to your address, we're going to knock on the neighbor's doors, just like what we do now when we try to find somebody. Where is he? Where is he? Well, nobody's seen him. Then we're going to call Banks and say, have you seen him? Is he over there at your hotel? Is he at the hospital, And then, we do missing person reports all the time if we feel like you're at risk. If the neighbor says, yeah, he's been in there and we hadn't seen him come out in 5 days, we're going to call Banks up and say, come over here, we need to do a well check on you. We're going to do our best to try to follow up with you, Johnny.
Okay, I heard the successes. Give me some of the failures that you think you can do a whole lot better on.
My biggest concern is, and we're working on this, but we all know budget, right? We've got budgets and, the state's department, as far as cuts, with partners and other things, will likely see that. So my biggest concern is serving that indigent population. This will give us enough time, though, within these 12 months to determine, because we have to do this with each of our service lines, how many folks can you serve per month, per year, under state dollars, basically. Does that make sense? So we haven't seen, our approved contract rate for what that looks like for the indigent or IPRS dollars.
Yeah.
Because while we'll have this case management and trying to, help get folks who are qualified to insurance, right? We're going to help to coordinate that. they may or may not be qualified.
We talk a lot about recovery. What are we talking about when we say prevention? What do we do? What do we do with 12-year-olds, 18-year-olds, somewhere in between, before they get to you? Have you got a program?
Have we currently? No, but I think Spark's going to talk to them about that later. They're doing the children right now. But no, I mean, I understand where you're coming from, and, you know, just having adequate housing, right, is a struggle for a lot of the population.
So my question was, I love what y'all do, Renee. I've worked with you forever. Do you think this will help open up your wait list for your CST and your ACT teams? Do you think this support from us, from the county, would help open that up?
Well, we really don't have a wait list, okay, right now. I mean, we're pushing the limit. We're pushing the limit, particularly on our ACT in Morganton. So what you see is a slowdown in openings. It's taken us a little bit longer to get people open. I think that's a natural thing. The same thing with our Morganton CST. We're pushing the limit, and so what we're doing internally is saying, okay, who's close to the Catawba County line? Maybe the Catawba County team can take them. We're also talking about for CST starting a second CST team, right? And that's the model that we're going to follow. We're going to get those groups full, and then we're going to start the second groups. We don't like a wait list, and I'm always pushing the teams. You got to get this one's a priority. And I said, well, yes, yesterday you said that one's a priority. Well, now you got two.
I have two logistical questions. So what kind of qualifications are you looking for the therapists that you would hire for either one of these two groups?
So we are looking for a licensed clinical addiction specialist, the LCAS, so they would be licensed in North Carolina as that addiction specialist. And then we're also looking for any CAD-Cs, which is, I can't even think of what.
They're not.
Good one, Paul, good one.
Yeah, it's just a. Who's CAD-C to help me with this? They don't have.
Certified
They don't
alcohol
have
and drug counselor, right?
Yeah, they don't have
Thank
the
you.
master's degree, okay, but they can be a bachelor's degree, they can be an associate's
Certification.
level degree, and they've gone through the certification. It's a different process, certification versus licensure. We already have several of the LCAS folks and several of the CAD-Cs on staff. One of our LCAS is in a supervisory role right now and has done this service with another agency. Well, both, and the other LCAS that's in our outpatient therapy department has done this service. They're very excited about getting this started. So we've got a good framework.
And what's your space look like at ACA for you to be running these groups simultaneously?
Yes, it
Because
would
you all
be.
are pretty tight there.
It would be, spacing would be adequate to cover, actually, we would use ROP for our ROP groups, the conference room there, and then we would have two group rooms. You know, one for psych-hot, one for IOP, morning sessions, evening sessions, and obviously some admin offices.
And we want you in the same building as the mental health folks are too, you know, for
Right.
continuity of care. And we want you in the building because Jerry's is right next door and we take breaks and you go over and get your soda pop, you know. Hopefully that's all you're going to get, but, you know.
Yeah.
And we're all right there and, you know, we kind of look out who's on our streets and who might need some help all the time. And this would just flow very well.
Other questions for these folks? All right, thank you, ladies. Appreciate it very much.
Appreciate it.
And up next, we have Alice Salthouse and the team from High Country Health.
Tegan and Renee did the duet, we're going to report. I'll sing alto. I'll go back to the other folks. Thank you so much for your time here today to listen to this. This is not a happy topic to discuss, but it is something that we really need in Burke County. High Country Community Health is a federally qualified community health center, and we are in with our brick and mortar, we're in 4 different counties: Avery, Burke, Surrey, and Watauga County. Last year, we served about 4,500 unique individuals with substance use disorder as part of their diagnoses. 46% of those out of all 4 counties came from Burke County. Burke County has issues like other counties do not. I don't understand why, but I believe this to be true. High Country Community Health is 12 years old as an organization. We served altogether for everything last year over 17,000 unique individuals with 70,000 visits. And we do a lot of things, but in our mission statement, it talks about, just like they said, that we do whole person care. We work with people with their medical needs, with their behavioral health. We have a dental clinic. We have a migrant farm worker program. Don't know if you know this or not, but Western North Carolina is second in the nation for Christmas trees. And so we need those, we need those workers in helping us with that. But today we want to talk to you a little bit about our request, and our request was what, 375,000, and how we want to use this money. And I am a person in administration. My name is Alice Salthouse. I am the CEO. I grew up in Drexel in Burke County. I also, it's sad but true, I had 3 brothers that have died from substance use disorder. So I have firsthand experience about how it affects the family and the families and the children and all of that. I have a son right now who is experiencing that. And I know many times, many people in our county, we talk about it in the side conversations, but we don't come out in public and say, I have a son with substance use disorder, because there's shame involved with it. But we want to be a part of facing that problem and getting people into a better place in their lives. And you talk about, prevention in the children. If we can help the parents and get the drugs out of the house, sometimes that's going to be one of the best things you can do in a child's life, is help their parents get away from substance use disorder. But today, there were some questions I feel like that maybe we can give you some answers to, but next slide. These are, Tom has put this slide together, but he's going to talk to you a little bit about the overall program and what we're asking for your assistance with this opioid funding to do, and then we'll answer some more questions. Go ahead, Thomas.
Thank you. Thank you, everyone, for your time today. My name is Thomas Wilson. I'm the Interim Director for Grants Management at High Country Community Health. And what I really want to harp on here is that High Country Community Health is already doing this work. We're already meeting people where they are. And like Alice mentioned, we already have a whole person integrated model that in this case also includes their family members. We have behavioral health staff as well as MOUD and MAT treatments in our office and outside in non-traditional street settings. We are not starting from scratch. Our organization has boots on the ground today and tomorrow and has for years, and we're just trying to immediately expand our capacity using these settlement funds. With no delay, there's not going to be any steep learning curve, and there's going to be no duplication within our own organization, as the providers are right here behind us that are doing the work every day. I also wanted to mention that we mentioned our whole family model. We're not only caring for people who are experiencing substance use disorder, we're not only providing MOUD drugs, we're also immediately connecting them to patient resource specialists, peer support specialists that are able to give them opportunities for housing assistance, food, retention, enrollment, and maintenance for public and private health insurance if they're eligible, as well as providing immediate services for their children, for their spouses, for their parents, whoever may be in need for direct behavioral, medical, even dental support services that we know are impacted. To continue this slide, I'm going to turn it over to our providers here. Dr. Thomas Meek joins us, as well as Tim Nolan, our adult nurse practitioner, who are actually on the ground doing this work every single day.
And like Tegan has said, transportation's a big deal too. We have a fleet of vehicles where we get people to their appointments and such. Oh, Tim gets to go first.
You want me to go?
Yeah.
Okay, so I'm Tim Nolan. I'm a nurse practitioner with High Country for quite a few years. I'm just going to be really short. So some of you know, some of you don't know. There's a massive problem out there of injecting drug use. This gentleman seems to be very aware of it. And a tremendous number of those folks do not access the buildings that we all work in for any number of reasons. You all know them. No transportation, trauma, deep poverty, no trusting companion that can get them to these buildings. So quite some years ago, it became clear that we need to go where these folks are and allow them to access care, because in this rural area, people just can't get to the buildings. Another big piece is stigma. People don't want to walk into a medical provider place and ask and tell somebody that they struggle with a substance. So real briefly, we go to where folks are at, to trap houses, to tents, to Walmart parking lots. And we meet them there with harm reduction, which is simply a carrot to engage them in care. And it works. It's a portal into further care. We provide rapid Hep C testing. And if they're positive, we draw their blood right then and there. And we treat their Hep C, because Hep C is curable now. So it's amazing how many folks, when their Hep C is treated, say, I don't want to do this stuff anymore. I want to get better. Or it's amazing if they say, I want to be off this stuff tonight. And we can dispense them Suboxone in that moment, which we do. That's their road to getting better. And that's, so in that team that we have is a medical provider. We have peers are what it's all about. They're taking over the world. So we have to have peers. We have a therapist that goes out with us and does therapy in the moment, in that setting, whatever their setting is. So again, short little steps. And what we want to have, and we do have, starting in McDowell County, we have a psych nurse practitioner that goes out with us once a month, because some of these folks are beyond my mental health capabilities. So we're seeing folks who are schizophrenic, schizoaffective, severe bipolar. That's beyond me, even though we see a lot of it. So it's wonderful to have a psych person who can, because if we don't treat their mental health, they're going to treat it themselves. So that's kind of briefly what we do in the field, and we're also trying to broaden it into more. All it is trying to see these people who are used to being watched but not seen. So we want to see them, and we want to give them attention, because they get none. And once someone gets attention and they're cherished, they can change. That's all it's about. And then they move to the clinic and they come for care. And they build trust, because they don't trust their own brother. So to trust, a trusting relationship is what it's all about. So I'll be glad to answer questions. Dr. Meeks can speak to it.
Yeah. Hey, everyone. I'm Dr. Tom Meek. I know a lot of you in this room and have worked with a bunch of you. I think I want to say first and foremost that, Jerry, I hear you. And, I want to be careful not to approach this from a defensive standpoint, but from one of pretty similar understanding. I think in that I have found myself saying, what in the hell am I doing? I'm going to give these people needles? And so I've struggled with that as a physician about, is that doing the right thing? Is that doing the best thing? Is that doing the smartest thing? But to the best of my understanding, boiling it down, there's risk in any type of treatment we do. You watch any commercial, whether it's anxiety or erectile dysfunction, there's going to be a laundry list of what it could be, maybe adverse side effects. So, and how did we get here? Why are we in this room? Because we as medical providers, with the best of intentions, most of us, were either convinced or effectively marketed into making the decision to prescribe medication to decrease people's pain and suffering, and it hurt a lot of people. And why are we here? We're trying to undo that the best we can. And so the evidence that I know in terms of harm reduction and needle exchange is that it is a public health approach. Yes, absolutely, there's some danger involved. It's a needle that a person can use to inject themselves. But in a public health standpoint, it is a sterile needle that will have the impact to decrease the transmission of sharing, to decrease HIV, hepatitis C, et cetera. And, the other thing that Tim spoke of, the name of our local hospital, it doesn't go by that now, but most people know it as Grace. And so Grace is, genuine kindness that's unexpected or not earned. The golden rule, helping your fellow man. And the opposite of that, in many ways, is the face that we all think of, the stereotype of addiction, disgrace. And so to witness firsthand individuals building trust through harm reduction and then get that as a bridge, that as the carrot to get them into the clinic where we can do comprehensive medical care is the goal. So.
One thing I wanted to say right quick about the needle exchange, or the needle, clean needle thing. Hepatitis C, we always think people know what we know in healthcare, but hepatitis C is the leading cause of liver cancer in the United States of America. And with the, getting that with the dirty needles. So my brother was a Vietnam vet, and that's where he started doing IV drugs in Vietnam long time ago. But he got hep C, and it just kind of stays inside and bubbles around, and then all of a sudden, boom. And he also drank alcohol, and they wouldn't let him have the hep C when they got the cure for it because he still drank alcohol. But then they said, oh, it doesn't matter, you can get it, years later. And so he finally got the cure for the hep C to keep from getting liver cancer, and like in less than a year, for all those years that he had hep C, he got liver cancer and he died in less than a year. The other thing about the needles is my son, who obviously had used dirty needles, got sepsis. You know what that means? Sepsis is bacteria in your bloodstream, and was in the hospital for 51 days because of the sepsis that he got. It got on his heart valves and this and that and the other. I mean, there's so much importance in the way we do things, and clean needles are looking like we're enabling, but it's also preventing some really bad stuff in people's lives. I just want to tell you that part about the needles, Thomas.
Yeah. Thank you, Allison. Thank you to our providers as well. I also want to add in for impact that a part of this program is that we're building for sustainability, not dependency on any settlement fund, on any grant fund. As a 501c3 nonprofit who is afforded FQHC status by HRSA, we are eligible to receive reimbursement from public insurances. We do not just start programs. We don't apply for grants for programs that we're not willing to sustain on our own. Of course, initial costs, it helps a ton to have opportunities like this to get a program to launch and expand in a way that it becomes more manageable. But we're really trying to sustain them. With the existing revenue resources that we have and our diversified funding base, our model is already built to last and is sustainable. This investment is not meant to disappear whenever the settlement dollars do. Instead, you're leveraging funds for a long-term return in this community and a huge impact at the individual and community level. Another innovative idea that we have with this is that as a part of our program, we intend to hire a psychiatric nurse practitioner to work in our clinic who is able to take on those more elevated cases that Tim mentioned that we're often seeing in the field and also in the clinical space that may be out of the purview of any particular behavioral health provider we have at the mid-level, being an LCSW or an LCAS. We're also seeking to hire a clinical pharmacist. And I know that that is an interesting phrase for some folks, but clinical pharmacists work directly with pharmacists as well as providers and patients to provide medication counseling, reduce medication errors, and offer opportunities for better medication adherence for each of our patients, which we know is a key factor for this population. And then the last thing I want to say before we open up for questions is that collaboration is our standard. We collaborate with several of the organizations in this room and beyond. We collaborate with different organizations in every single one of our counties. It's not just a buzzword, it's a philosophy for this organization. We believe that no one organization can truly solve the opioid crisis alone. That's why we work side by side with Port, first responders, social service partners, and we try to ensure a seamless continuum of care, whether that's whenever Tim meets somebody on the street while he's doing outreach, getting them involved with Dr. Meek back in the clinic so that they can have continual in-office treatment and then reaching behavioral health services. We know how drug use and abuse can affect someone's dental health, and we're learning more and more through reputable public health studies how dental health impacts whole person care and health and well-being. So connecting them to our already available dental access program. We want to be able to create solutions as a group with all of us that serve the Burke County community that can multiply the impact that each of us are creating at every level and with each agency involved. If there's nothing else, then I think we're ready for questions. Thank you.
All right, thank you very much. Any questions for the High Country folks?
So I did not mean to hijack the topic and just talk about that. I do appreciate the responses to my concerns there. I would want to look at more data to be 100% convinced, but
Let me just answer a little bit more to that.
All right,
Because
and
my
then
experience is folks that do needle exchange, and I've been doing this for a while, so many of them move off of the needle. So many of them say, no, I don't. It's really only an entry into engagement with their recovery spectrum.
Yeah, and I appreciate that perspective. It would take a while for me to be able to actually have a change of mind, but you guys have given me stuff to think about, something to look into, so I'm grateful for that. But I do have a question. It says you provide access to Suboxone or other FDA-approved MAT medications, and then like below that it says you offer integrated services. One thing I was wondering is do you provide MAT without integrated services, or is it required that they partake in integrated services such as peer support or something like that to get the medication?
It is. There's a whole level, like if you begin, when you start, you have more, as you work with the behaviorist, it's more intense, and some of them, we share with a caring alternative. And then as they get better and better and show up without any substances in their urine screens, that's a good thing. And whenever they, act differently as well.
So let me be clear on that. So, and thank you, Alice. Yeah. But several years ago, the guidelines were, yes, a person receiving MAT has to be engaged also in therapy, some level of, groups, whatever. Those national guidelines have changed. So we don't require that I cannot write for you if you won't engage with our therapist. Those are no longer the current guidelines for care.
Okay.
But certainly we steer people that way.
Okay, I appreciate that.
I would jump in just to sort of give my take on it as well, because I've struggled with that. The contingency model, meaning here's the carrot, here's the Suboxone, but here's the stick. If you don't show up to group, we're not going to give you your medication. I operated in that context for most of my career, which has been a while, 20 plus years. And then, leaning more into low barrier, not having the conditions. There are no strings attached. Obviously, if you go all in and go to group, there are numbers to show you're probably going to have a better outcome. If you're a diabetic and I prescribe you insulin, but you go see the dietitian, you're probably going to do better. But that doesn't mean I'm going to not prescribe the insulin. So.
Okay, thank you.
So I kind of have more of like a statement than a question, because I studied what you guys do, but just for our committee, in case so you understand, and correct me if I'm wrong, these are kind of the individuals you don't really see. They're in the street, they're underneath the bridges, they're giving out doses. I've had friends of mine that have said, oh, I saw Tim, and he said hey to me. You know, I mean, they know them by name, a lot of these individuals. And with the needle stuff, it's impressive to me that you guys are handling a massive addiction problem and at the exact same time, a public health crisis. There was once a time where we were battling tuberculosis, AIDS, all of those things, and as our public health system has gotten those things under control. And it's by doing things like that. So if we were to, by giving out the clean needles, we're coinciding, like at the same time, keeping down the Hep C issue. And that's a huge thing. It keeps it out of our schools. It keeps it off of our playgrounds, so that kids are not getting Hep C on accident. And I genuinely appreciate that and the work that you guys do. So I mean, I think that this is extremely needed. These are the guys that are handing out medications to people who don't want to come in, who can't come in, who may be so sick that they can't. And they may not get it this first time or the second time or even this year, but eventually sometimes it clicks, and when it clicks, it clicks. And I appreciate you guys working with some of the people that we don't get to see that come into the buildings. It's huge. And I offer you guys my full endorsement and support, and thank you.
Another thing for the low barrier care is giving out Narcan. That is if someone overdoses, you find somebody laying that's turned blue and barely breathing, that has lowered the death rate, hasn't it, from the Narcan being out in the community?
I hate to do this again with the detail. Could you just cite all the positions that you're thinking about hiring with these funds?
So with these funds, we intend to hire a behavioral health provider. That's going to be a mid-level, either a licensed clinical social worker or licensed clinical addiction specialist as a full-time role, a psychiatric nurse practitioner as a full-time role. We are going to use funds to pay for a portion of our MOUD medical provider salary. So that's not a new hire, that's an existing position. We will also support a medical office assistant salary. And then we are working to include, this would be actually just a kind of renaming and adding to the scope of a position, which would be a community resource advocate. They would be the person that helps connect them with our enrollment specialists for insurance access and maintenance, food resources, as well as housing support. The clinical pharmacist, and then of course the 2 enrollment specialists, which would be at 0.5 FTE each.
Thanks.
Thank you.
That was a total of 375, right?
Yes. All right, thank you very much.
Hey, Jeff, hold on just a minute.
Okay.
I've been asleep up here, I woke up. Dr. Meek, I've listened to you a lot over the years, stand in front of us and speak. Obviously, we know that it's been said that the average age of a first-time user in Burke County is 12 and a half years old. And understanding what High Country does, how do we get into a prevention program? Is there any way that High Country even looks at that? It's
Right.
when we're looking at, because you go out and do a lot. Do you go out even further down there?
Yep. Yeah, so prevention efforts in the past historically have not set things on fire.
Is that a weakness for everybody?
Yes. So the DARE program in particular, great idea, but the numbers don't bear out that it made significant, meaningful impact. Great idea. And so I hear that question, I ask myself that question, what can we do to make it better? So most of the time when you answer a question with, that's a good question, that means, I don't know, usually. But some of the collaborations that we have but I have folks from Spark that bring patients to me that are keeping their children only because they're plugged in with Spark and only because they're coming to see me. So the parents are coming to see me. They're making progress with their sobriety, recovery, abstinence, whatever word you want to use, and their children are still in the home. So that's one collaboration. Another one is through Burke Recovery. They have a program that that addresses these needs, oftentimes from our clinical encounters, and they can go out and meet adolescents oftentimes at school. I'm not really well versed in the details of that, but, you know, the broad strokes of it seem extremely valuable. So the collateral damage, a mother or a father, an aunt or an uncle have an adverse event, a rock bottom event, an overdose event. The kids see that. The kids experience that. And so oftentimes, without resources, how do they respond to that? Oftentimes inappropriately. So it's definitely a need.
Alice, what do you think your best successes have been? If you'll come to that mic, please.
Well, I will tell you, I don't know many people. I mean, Tim gets called to go talk in communities all over because we go out into the communities where people are. And I feel like that meeting people where they are, building relationships, Tim's told me many a time, it's the trust. You show up when you say you're going to be there, and you're there. And they know that if they need something, you'll be there for them. So the greatest success, I feel like, has been that. It is a battle. It is a hard battle, biblical almost. You know what I'm saying? It's like, but we don't give up. We keep trying, and building that trust is, I think, the number one thing that has helped with this situation. Does that make sense?
Oh, yeah. Okay. Thank you so much.
Other questions? All right, again, thank you folks for coming today.
patience to see, so I'm making them go back to work.
Okay.
Is that okay?
Mr. Moderator, before we continue on, can I offer a suggestion, just a possible, so I would like to maybe adjust some language in the opioid services agreement with High Country Community Health, just to add, provider must follow SAMHSA guidelines for diversion prevention, keep all MAT medication in secure locked storage, and maintain accurate dispensing logs. Doses will be given under observation unless the patient meets take-home criteria. Random pill counts and drug screens will be done to confirm proper use. A monthly report of medication inventory, dispensing, and any incidents will be sent to the county. The county may inspect records and storage at any time, and any suspected diversion may result in immediate suspension of funding. The reason I would suggest adding that is simply because when you're giving out medication, I get nervous because I've seen a lot of misuse in the past, and as people who are providing the money for it, I don't want to be responsible for that. So if there was something just simply added that makes sure that the guidelines are followed, that would just make me comfortable. There's not an issue. I think it's addressed, but I just would like to make it a little clearer.
Thank you so much, Jerry, for bringing that up. Thankfully, these doctors and the providers are covered under huge law. Their licenses are covered. And so those things are already built into place. And unfortunately, there's not enough manpower that they can hire to do that. I mean, in a dream world, I wish that we could stop the selling of the drugs in the jails and the prisons. I'm sure Sheriff Banks feels the same way. It's going to happen. They're going to trade their drugs for something else, and we're not going to be able to prevent it. But thankfully, we are all covered under certain laws with liability, with DOJ, especially when it comes to narcotics. The DOJ is heavy on all of us. That will take care of a lot of that. But to expect them to really do those pill counts, I don't know that they'll have the manpower to be able to fulfill that obligation, or that we even have the funds and the resources to provide the manpower to fulfill that obligation.
Well, one thing we do is, so I'm licensed under the State Pharmacy Board to dispense in the field, and that's antibiotics, that's what we see out there. I have to be accountable to our pharmacy for every script I write. So she tracks me, where's this script, so there is tracking of what we dispense. That's
Okay.
the least I can say.
And Jerry, thank you for that. I'm in agreement with what both of those responses said. As also a 501c3 that is reporting to the federal government, we are bound by HRSA as well as SAMHSA regulation in order to be able to keep our federal status. And we are reporting to the federal government at least on an annual basis, and also to all of our other funders, normally every 3 to 6 months. So we have scrutinous policy to be able to be accountable for the medications that we dispense, especially now that we have an in-house pharmacy that does keep track of inventory in that way, whether it's being used in the field or in the clinic. But we would definitely have a much, much bigger problem on our hands if we were not abiding by the SAMHSA regulations for medication distribution.
Right, yeah, and I assume that was already in place. I just
We're
wanted,
amenable
like,
to any,
on the
yeah,
paper.
any
to make me
introduction or
comfortable.
any addition, we're happy to review it as well whenever we're going through a contracting process. Thanks.
Can I ask quick, maybe to help, maybe help Sheriff Banks feel better, or Jerry? If, say, someone is known to be selling their drugs, and then they're repeatedly do it, you know they're doing it, is that maybe a move for discharge? Like, we can't keep doing this?
Yes. Yeah, it's a move for discharge, and there's certain also checks and balances that we have for that, including regular urine drug screenings. If you're being provided with a certain medication and it's not in your urine, then where did it go? And you should have a good option. And then also, with the way that we're distributing for medication-assisted therapy and medications for opioid use disorder, is typically in sight of the actual provider, correct, Tim?
I missed that. I'm sorry.
Whenever you're administering MAT or MOUD drugs, it is within your site. It is, you are administering it at the time. They're not self-administering.
At a time.
Correct.
So we dispense a week at a time.
Okay, thank you.
Thank you.
By the way, as the person who may have brought up the most negative things to say, I want to say I appreciate High Country Health and the Caring Alternative. I'm just adding my opinions, so don't anyone be mad at me.
So you're not the one brave enough to ask the questions, and we do appreciate it, because it gives us an opportunity to explain, so thank you for doing that.
All right, Dr. Sanders?
Next, we have Terry Herman and the Spark team.
All right, good afternoon, everybody. My name is Terry Herman. I am the Senior VP of Strategy and Development with Spark Services and Programs. I have Shanda Woody with me here. She is our VP over our mountain region, and Burke County is the hub of what we consider to be our mountain region. And we are pleased to present Family Center Treatment Recovery to you guys today for review and consideration. I'm going to talk a little bit about our history as Spark, and then turn some Burke County specific information over to Shanda. So Spark has been in existence providing services to North Carolinians since 2015. We opened up our first Burke County case in 2017, so we have been in this community for quite a while. We do have an office that is located just a couple blocks over right here in Morganton. In Burke County, we're currently providing family center treatment to children and families, community support team for adults, as well as peer support services for adults. And we have, all of that funding is primarily Medicaid at the moment. We are contracted with all 4 tailored plans in North Carolina and all 5 standard plans in North Carolina. And we'll be contracted with the newly, to be launched in December, Child and Family Specialty Plan. So we do have a lot of Medicaid capacity. The program that we're here to talk to you about today, Family Center Treatment Recovery, is not yet a Medicaid billable service. Part of the goal through these funds is to help continue to move the needle towards Family Center Treatment becoming a Medicaid billable service. We are in active talks with both North Carolina DHHS as well as several health plans. And it's probably within the next 6 to 9 months, it will become a billable service to open up access to more North Carolina families. We are nationally accredited through CARF for 2 types of services: intensive family-based services for children and families and adolescents, as well as community integration and mental health, which is for our adult services. And last year in 2024, across Spark, we served over 1,600 unique individuals through a combination of our child services as well as our family services. I'm going to let Shanda go a little bit more into some of the things that we are doing in Burke County.
Yeah, so specifically in Burke County, like Terry mentioned, we have family center treatment. Oh, sorry. We have family center treatment on the child side, and then we're offering a community support team and then a peer support team on the adult side. What we are doing that I think is really unique is, and will be an extension of this with FCTR, is with our FCT families. When those families are identified, usually through DSS referral or a DJJ referral, we are treating the entire family, not just the identified child, but the entire family. And so oftentimes what we see with our parents, if they have their own mental health or substance use issues, and so then we're able to attach or refer them to the community support team or the peer support team. So now we're really wrapping these families up tightly. We're able to give them family-centered treatment on one side, which is really identifying or addressing those generational family trauma issues that we see often moving towards like substance use or creating those substance use issues. But then we're also able to address the adults in the home and provide their own mental health and substance use treatment on the peer support and community support team side. So sometimes these families are being seen 3, 4, 5 times a week by our teams. FCTR is an extension of that, which is something that we're hoping to really be able to launch here in Burke County, and it to be a pilot program for seeing that FCTR become a Medicaid billable service in the very near future.
All right, so a little bit more about family-centered treatment recovery. Guys, I am really excited about FCTR. I have been involved with family-centered treatment since 2003. If you're wondering, I did start when I was 12. Because I'm definitely not old enough to have been involved with this model since 2003 otherwise. But as somebody who has grown up professionally involved in family-centered treatment, having the ability to serve families who have a substance use disorder is very, very exciting, because I know throughout my career so many families that came to us with family-centered treatment, there was substance use disorder somewhere in that family system. And with family-centered treatment recovery, our practitioners and peer support specialists have that specialized training and education and skills to really be able to address that substance use, along with the trauma-informed interventions, and then also the very experientially based, family-based strategies that we use. One of the unique things about FCTR, and I think this might speak to your question, is that it could be the adult caregiver or the child who has that, or both, who has that substance use disorder. So our goal through this is that we are working with families where that substance use disorder has already been presented, that family is known to Department of Social Services, juvenile justice, probably our law enforcement friends. You guys know these individuals, but we're also hoping to intervene earlier in that spectrum. Maybe the school is having some challenges where there's some things happening. Maybe the pediatrician is knowing something. So we're able to get in there early. And by having either the adult caregiver or that child be the one with that substance use disorder, that opioid use disorder diagnosis, we can get in there earlier. When families have already been identified and that social services team has already maybe done that removal, we're able to go in and help do that reunification work and help speed up that reunification, because we don't want our kids to linger in foster care, bouncing around from placement to placement. We know the more placements that a kid bounces around from, the higher the likelihood of trauma, the higher that likelihood of substance use and other trauma presentations later on in their life. So if we can get in there and help to create safety, either to prevent that removal of that child or to do that reunification in a really safe way, we want to make that impact within this county. Our referrals for this program can come from our social services, our child welfare partners, juvenile justice, law enforcement, our community partners that are doing other services in the community, partners, our local managed care entity, our Taylor plan that is here, with the goal of being able to promote permanency, recovery, and improved functioning across multiple domains across that entire family system. So some of the families that we're working with is not just adult caregiver and kid. Ooh, I wish that'd be easy, right? We have multiple adult caregivers, multiple generations of adult caregivers in that home, multiple siblings. And so sometimes our family systems are 10, 12, 15 people living in that home, and family-centered treatment works with that entire family system to help promote that recovery versus that a very individualized approach. We're bringing everybody, even the little babies, at an age-appropriate language, of course, into that treatment philosophy so that the individuals and that family system can recover together and be together there for each other. And when there is a relapse, I don't want to say if there's a relapse, but when there is a relapse, it is not an automatic, oh, you had a blip in your recovery, we're going to kick you out of this program. We work with that family system. We reassess safety. We do more relapse planning. We wrap them up even tighter and see what other interventions we need to do to help continue to move that family system towards that path of recovery. To support that recovery, we are doing weekly drug screening within that family. So there is at that home, that a point of care is what it's called, drug screen, that individual with that substance use disorder will engage with. We also do contingency management up to a total of $599 per year per family, and that allows us to support and celebrate milestones in treatment. So, hey, this individual who was not passing successfully some of their drug screens starts passing some of those drug screens. Maybe they get a gift card to go to the movies as a family. Maybe they get some, I don't know, gift cards to the local grocery store, or something that can help incentivize them, again, from that family system, but also helping them to promote all of those different milestones within that recovery model. Our goal is to be able to serve 20 families throughout this contract year. I'm not going to read every single word of this to you guys, but essentially part of the contract terms is we will lift our family-centered treatment recovery program. With that, we will provide that training in partnership with the Family Centered Treatment Foundation. So we will have 2 FCT practitioners as well as 1 certified peer support specialist. We will have a supervisor who has their CDAC, and we also have a clinical supervisor who has, I'm probably going to get all of her letters wrong, I usually say she has all the letters. She is an LCAS and a CCS and a LCMHC. She has all the letters. So that means she is able to supervise clinically both the mental health as well as the substance use needs of the individuals that we are supporting, and she has, through those certifications, years of her professional career that is dedicated to this population. With this, one of the things we have talked with, through our performance contract with, is $25,000 initial startup expenses to make sure that we are getting the staff trained. Practitioners that are delivering family-centered treatment recovery not only have to go through the regular 9-month certification process for family-centered treatment, they also, in addition to that, have to go through the family-centered treatment recovery certification process, which is an additional online training component, as well as 13 field-based competency tests, which that means that somebody who has a lot of knowledge and experience is watching that practitioner to deliver those interventions with families to make sure we are delivering the best practices possible. And with this, again, to assure our committee that you are getting what you are paying for, this is a kind of a fee-for-service model at $200 per hour per family served. And that will include individual work with individuals within that family system, family work, case management, referrals, care coordination, all of the pieces, the drug screening, that gets sort of that whole kit and caboodle that really is customized to wherever that family is. Shanda mentioned some of our families are getting visits 3, 4, 5 times a week. We customize that treatment intensity, and it titrates up and down based upon where that family is and what they are needing. Some of the metrics and timelines that we are looking for. So by month 2, hire and onboard our 2 practitioners as well as our certified peer support specialist, and complete the readiness expansion assessment with the Family Centered Treatment Foundation. So Family Centered Treatment Foundation, as the purveyor of the model, has to license any provider to do this model. So I can't just go, oh, I'm going to go do family-centered treatment as a provider. I have to apply and be deemed to meet certain levels of criteria, and then I get technical assistance and lots of guidance from the Family-Centered Treatment Foundation. So even though I have been doing family-centered treatment since 2003, we still have to complete this readiness assessment as an agency, and the Family-Centered Treatment Foundation partners very closely with us to launch this model. At the end of the month 2, our practitioners will have completed that online training program that I mentioned that gives them sort of that base set of skills to be able to deliver this model. By month 3, our goal is to be able to identify and complete intakes for a minimum of 4 families Based on some of the conversations that Shanda and her team have, I feel very confident we're going to blow that milestone out of the water because we already get calls regularly for families where there's somebody in that family system that has that substance use disorder. At the end of month 9, our practitioners haven't completed that field-based competency checkoff because that is, again, they're practicing those skills with those families in that live field-based environment. And then at the end of month 9, we're having at least one family who has graduated from family-centered treatment recovery. Some of our outcome targets, again, 20 families in that first year, having 80% or greater reunification or stabilization. So I can tell you since 2015 in our regular FCT program for Spark, we have exceeded more than 80% of the families that we have worked with who have either been stabilized in that placement, meaning they have not been removed by DSS or DJJ, or they have been reunified with that family of origin. So we wanted to make sure that we set a target around that reunification and stabilization. Having 30% or greater decrease in those positive drug screens at that 90-day mark. So again, working with those individuals, making sure that as we continue to go, we have more continuous days without use, right? We don't expect somebody they enter FCTR that day 1 and all of a sudden magically they stop using substances. If we had that magic wand, we would be really, really rich and we wouldn't be asking you guys for money because we would just be the most popular people in the world and we wouldn't have a substance use problem. So I'm still looking for that magic wand, but for this, we are looking for that metric within that 90 days. And then client satisfaction. What are families saying back to us about is our work helping, supporting, helping them to create safety in the home, helping them to achieve their goals, helping them to have better relationships with their children, helping them to do better in school, helping them to gain employment, feel more stable at home. So again, having a minimum of 85% of our families indicating satisfaction within our FCTR program. Some of the other metrics that we are looking at, one of the things that's really, I think, pivotal in our family-centered treatment and family-centered treatment recovery model is face-to-face within 48 hours of referral. So Jerry calls us up and says, hey, I have the Smith family for you, and we meet that Smith family in 48 hours, right? Because most of the time when that call is coming into us or that online referral submission, that family is not having their very best day, right? So we know we have got to be able to respond quickly and efficiently and go meet that family. Now, does that mean that we're with them for hours and hours and hours on end on that first day? No, but we want to get in there within 48 hours to meet them, introduce them to the concept of who Spark is, who their practitioner will be, what does family-centered treatment recovery look like, what are the things that they're going to be committing to. So we know we've got to be able to do that quickly. And we want to, again, make sure we're working with the individuals in those families to improve that functioning across multiple life domains. And part of that metric is having more continuous days without substance use. All right. I know I talked really, really fast. Sometimes my New York comes out. So I'm very happy to ask questions. Or not ask questions, answer questions.
Yeah, questions.
I mean, I have lots of questions, but I don't know if they're appropriate for this venue.
Questions for these ladies?
I do, okay. Sorry. All right, I have a few questions. So currently, this is not Medicaid funded, correct?
Correct.
And you're expecting this to be in the next 6 to 9 months?
That is the trajectory that we are on, yes.
And that's also maybe like a hope too, like fingers
It is a
crossed?
huge hope because it would open up access. Right now, family-centered treatment recovery is only in 3 sites across the country, and they are all grant funded. So we are hoping to not only be the first to get it Medicaid funded in North Carolina, but again, to really pave the way to create that access for more and more families to have access to care.
Absolutely. Is there right now a rough draft service definition?
There is.
There is.
There is.
So is this the model that you're following?
Yes.
With the CADC over the 20 families?
Yes, I am on the work group that is drafting that. So I had the opportunity to help kind of shape both the RFP response that we did and then what is going over to DHHS.
That's good. That's good. And then in your contract, it was I think I may have it wrong, $3,200 per family participant. So this is per family unit and not per family
member?
Per family unit, yes.
Okay.
And then we did change that up to satisfy some of the questions that some of the members had, to move to, from that monthly case rate to an hourly rate, so that there's more assurance kind of of what you're buying, right? But yeah, so that initial proposal was per that family unit. So whether there was 2 or 3 people in that family unit or 10 people in that family unit, it's the same rate.
That was my concern. I was like, what if you have a family that has 7 people and then another one has 3? I didn't want,
You get a lot of bang for your buck if it's a really large family unit.
Right. And then will staff be rotated on the team, or are they going to be specifically assigned per family?
They will be specifically assigned. So each practitioner will hold 5 families as their caseload. So caseloads are small because the work is very intense. So we'll have 2 practitioners that will hold 5 cases each at any given time. That peer support specialist will rotate amongst those 10 families. And the amount of time that that peer support spends with each family is going to be different based upon what that family needs. But yeah, each practitioner will have a dedicated caseload.
And then how often will the CADC see each family, if there's one CADC over the 20?
So the supervisor will have the CADC, and then the clinical supervisor has the LCAS and CCS. So they'll be brought in as necessary, but the practitioners, Shanda, I know they've expressed, and they're already FCT certified, but our practitioners, where are they in the terms of certification? I know that some had expressed some interest.
So we have 2 practitioners that are currently certified in FCT, and so the extension of FCTR will bring about those substance-specific, recovery-specific intervention strategies that they're going to be learning within this model. So they'll be supervised by the CDAC and the LCAS, but the 2 FCT practitioners are being trained with the FCTR model through the foundation to provide those interventions and strategies.
So an FCTR is a peer support with that additional
No, these are bachelor level qualified professionals
GPs.
that
Okay.
are certified to provide FCT.
Thank you. And then the incentive money, is that being built into the service definition?
The contingency management?
Right. Yes.
That is in the definition,
I'm
and we
hoping for
have fingers crossed and
Okay.
toes crossed and everything crossed that because that's very different for our Medicaid space. But it is something that all of the evidence across the 3 sites nationally has been a huge piece, and it is in a lot of best practices in the substance use world to have that contingency management. So we are pushing for that. We're also looking at what some of those Plan Bs are, if that is not a Medicaid funded part of that rate.
What would be one of the Plan Bs?
I mean, we've just started tossing around ideas. I mean, it would have, some of the companies that have talked about this is like, do they want to do some individual, like sort of fundraising specific for that? Is that something that the companies are willing to kind of donate or eat out of their administrative budget? I mean, each of the teams is kind of tossing around some different ideas. But in all 3 of the grant funded sites right now, that is something that is funded through the grant.
Okay, and then last question, I'm sorry.
You're good.
I'm not grilling you. Say a family quits answering the door. How many more times until that family do you move on?
So we try not to have cut and dry policies. We're going to keep going out there. We're going to call, we're going to keep calling, we're going to text, we're going to keep going out there. But we also try to get emergency contact for each of our families. So let's say Katie is the mom for a family system that we are working with. We're going to say, Katie, in the event of emergency and we can't get you for 2 days and we're worried about you, who do we have permission and we have a release? Who can we contact so we can check in on you? So we've already built in a lot of that with our teams and sometimes families will say, hey, like, here's my neighbor, here's my aunt, here's my pastor, and we get releases to be able to. So if a family does start with that engagement or start answering the door, we have multiple kind of places to outreach to be able to re-engage them.
Okay, and I'm sorry, I said last question, and I've got another one. I don't have a service definition to look at, so I'm just asking, so what constitutes a billable?
So what would constitute a billable event is going to be the same as what it would constitute in our family center treatment model in terms of Medicaid, right? So we have the ability to bill for direct and indirect work. So that direct work is I am in person in that family's home doing direct therapeutic interventions with a member of that family. That indirect is
I'm on the phone doing an in-between session check-in with that family, or I'm doing some referral and linkage. Now, if it is like a 3-minute, Katie, how you doing? We're documenting that in a note to chart. In our Medicaid space right now for family-centered treatment, it is a monthly case rate. So we have to hit a certain metric of intensity to be able to build that monthly case rate. So with this in that hour, again, that 2-minute phone call, or that I tried calling Katie and I just left her a message, is going to be documented in that note to chart. That's not a billable event.
Thank you. That answer your question?
Does this become sustainable for y'all if Medicaid is approved?
It does.
It does.
I couldn't tell whether you were excited about FCTR or not from your presentation. I spent a lot of time on your website, and you know, I just, anytime we're talking about, we're hoping Medicaid, that bothers me a lot.
Yeah,
when we're
me
hoping.
too.
Medicaid. The 3 programs across the state, do they have any success numbers? And who are you talking to in North Carolina Medicaid about this program?
So the Family Center Treatment Foundation had a meeting 2 weeks ago with multiple members with inside DHHS on the Medicaid side as well as the DMH side.
NCDHHS?
What's that?
NCD?
Yes, sir. Sorry about that. So they have met with some of the top Medicaid and mental health leadership within the state. We have also been meeting.
What does NCDHHS say about this program to you?
So they are very excited about this, and they are the ones that requested that draft service definition, as well as the health plan, the Child and Family Specialty Health Plan that will be launching in December. So we are working very closely with them, as well as they are probably the furthest down the pike to lifting this definition.
What if hope runs out and some of the money's not there? What do we do?
We continue to deliver family-centered treatment as we have been. So we can deliver family-centered treatment to individuals where there is some substance use. Where it doesn't get is all that extra sort of stuff in there, but they can still deliver some of that substance use treatment. We can partner with our peer support specialists, our community support team. We have ACT in other parts of the state. So we can kind of cobble together some services. It's just not as kind of wrapped around tight in a nice bow from that family systems perspective.
Are you meeting with HHS again anytime in the near future about this
Next Friday.
program?
On the 18th.
On the 18th? Okay.
Yes, sir.
Other questions for these folks?
What's the criteria?
To have a mental health diagnosis or substance use diagnosis. That's it.
But for the FCTR,
For FCTR, yeah, so it would be,
substance use.
there would be somebody that has that opioid use disorder diagnosis or that polysubstance use diagnosis, again, on that child side or that adult caregiver side.
So it can't just be mental health diagnosis for the FCTR?
For FCTR, they would have to have that substance use diagnosis somewhere in there for this particular set of funds. With what we have put into the Medicaid one is we didn't put that primary opioid use disorder because we just said, you know, a substance use disorder diagnosis.
And I think the plans were 6 to 9 months, is that correct?
Yeah, yes, 6 to 9 months in treatment.
And so what if you're not seeing what you want to see at 9 months?
Again, I think that's
If they're
going to,
making progress, I'm sorry, if they're making progress, if they're continuing to work towards their goals, then we're continuing to serve them,
Even past the 9 months?
even past the 9 months. Yeah, if we're working towards goals and we're seeing progress, we're not stopping at 9 months. If we're continuing to see success and they still have a need for that level of care, then we're continuing to provide those services. We do that now in FCT. That's exactly the way we run our FCT program.
So I'm just curious, when would the graduation take place? My concern is the individuals that just stay on Medicaid and on a service, and they're just build and build and build.
great question. So there are 4 phases of treatment with transitional indicators. So as an evidence-based model, we can absolutely, it's a blend of we meet people where they are, but we also have metrics that help us say this person or this family is ready to move from phase 1 into phase 2, from phase 2 into phase 3. And then these are the things that we're looking at in terms of, it's called our generalization phase. Has this family adopted these skills to be able to generalize and adopt ongoing recovery, ongoing stability, ongoing all of these pieces based upon what their goals are. So nationally for FCT, the length of stay is about 6.1 months. Now, that means we do have families that are in FCT for 8 months because it took us a little longer to hit all of those metrics in that 4th phase of treatment. We have some families that graduate at 4 months because they were motivated and ready, and they just zoomed through, but they still hit all of those pieces. That's the beauty of having an evidence-based model, is it does not allow you to just linger and let families and individuals stay in treatment for ever and ever and ever and ever and ever and ever and ever.
Thank you.
And then we also have to, with Family Center Treatment Foundation, if our data says, hey, this person is hitting that 8-month and we're still kind of stuck, we are required to staff that for extension with our Family Center Treatment Foundation. So there's lots of safeguards with an evidence-based model to help ensure families are getting what they need from a dosage perspective, a frequency perspective, all of the evidence-based interventions. And then if somebody is, if the data appears that somebody is struggling, it's kind of an all hands on deck to figure out what do we need to do from that family-centered, person-centered perspective to help them achieve those goals.
Great, thank you.
All right, ladies, thank you very much.
Thank you.
Just had one question. What's graduation look like?
It's a celebration. So it is, we're reviewing kind of where you were. Like, this is where you were when you started. This is where you are. We're celebrating the big milestones, the small milestones, and everything that happened in between. And that family is really getting to craft that and own that, right? So part of one of the things that we do with families, typically about 6 weeks or so before graduation, is they do a giving back project. So our families do some sort of activity to give back to their community because they have received this service, they participated in the service, it's not a service that they pay for. So we do a giving back project that is personal and meaningful to them. So we've had families that have helped build a community's first food pantry. They have done Habitat for Humanity kind of building. They have done trauma scrapbooks for domestic violence survivors that go to the shelters that say, I believe in you, don't quit. And everything and anything in between based upon their personal goals and the things that that family is really excited about. So we celebrate that. Sometimes we do like a little pizza party. What are some other things that we do at the graduations?
Some of our families have, we let them pick what they want to do. Some of them want to go out to eat to a fancy restaurant. Some of them want to go to Bode's. We've had families choose to have a big family meal and cook, and so we provided all the necessary ingredients to cook whatever meal they wanted to cook together, because that was one of their goals, was to actually work on that family unit, the family systems piece. So it's whatever the family chooses as their celebration is what they end up doing. Yeah.
All right, thank you very much.
All right.
Thank you.
All
Thank
right.
you.
Ladies and gentlemen, we're coming up on some time, and I think there's another meeting in this room, but I do want to give just a few moments for public comment. If you would like to make a public comment, and sorry I'm looking the wrong way, but if you're here and would like to make a public comment, please come to the podium and give just a few minutes for public comment at this time, and try to keep moving. Anyone interested in making public comment? All right, seeing here none, we appreciate everyone's attendance. That brings us to our items for decision. Ladies and gentlemen, we've had three presentations for three different programs. Again, want to appreciate each one for your coming today, making these presentations, for all the effort that you've made to get to this point. So at this time, I'm going to begin with a caring alternative. We heard their presentation, and I'm going to accept a motion to endorse this program as presented.
Motion.
Have a motion and a second.
Second.
All those in favor signify by the uplifted hand. I believe that is all of us. Okay, thank you very much. Then we'll come to High Country Health Care. I would entertain a motion on this program.
Motion.
Have a motion and a second. All those in favor, please signify by the uplifted hand. I believe that is all of us.
May I ask a question about that?
there was a difference in what was presented on the slide and the amount of the request and what we had presented to you. Was that just a mistake or is that different?
So it was, in the draft contract, it was different, but we can revisit
Okay.
that total amount.
Okay, sorry. I just,
Because these motions are to proceed with contracting.
Yes.
Okay. All right, and then thirdly, we heard from Spark. I'll entertain a motion on this program. Have a motion
Second.
and second. All those in favor signify by the uplifted hand. And I believe that is everybody. All right, well, thank you very much. I'm not aware of any other business to report. Dr. Samuels, anything else from you today?
Yeah, I do want to mention, in your agenda packet, there is a flyer for Overdose Awareness Day. Our Peers Partnering for Excellence group has done a fantastic job. Brandy leading that group. They will be planting a tree on August the 30th and setting up a memorial garden there. And also on this flyer is a QR code. Even if you're not able to join in the memorial celebration, you can scan this QR code and it takes you to the national map of memorials for lost loved ones due to overdose. So if you have a loved one that you would like to put a memorial in for, you can scan that QR code and it'll go on the national map, and we'll have a QR code of that at our memorial garden. So if you can join us, it'll be August 30th.
All right, thank you. Any other matters of business? Again, I want to thank all of our program providers today for all the work that you have done to prepare for this, and we look forward to a great deal of success going forward with each of these programs. So again, thank you very much. Thank you to our advisory committee for your time today. And our next meeting, Katie, can you tell me when that is?
Our next meeting will be September 16th.
September 16th. So put that on your calendars. And with that, I'll entertain a motion to adjourn.
3:30. Okay.
Motion.
Have a motion and a second to adjourn. All in favor, signify by the lifted hand. I think that's everybody. Thank you very much.
3:30? Yes.